Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to another one of our virtual conversations here at State of Reform. My name is DJ Wilson, one of the hosts here working to foster these conversations and these virtual tables and settings so that we can continue to build community, continue to wrestle with some of the challenges that face both us in healthcare and us in public policy. And we're honored that you allow us to play this role. We got about 100 folks signed up for this conversation today, and we're super excited to bring it. And I want to just first thank our media partners, TVW, who will be sharing this, of course, across their network, and of course, the people who will see it at our site at stateofreform.com. We also got to thank sponsors, of which we have 3 for this show, and we are honored that they put wind in our sails and allow us to play this role. One is, of course, Community Health Plan of Washington. That's the health networks, the health plan of the FQHCs here in the network in Washington State. It's been around over 25 years and providing that safety net for Medicaid beneficiaries in Washington State. Kaiser Permanente of Washington, it's, of course, providing top-of-class care, really top in terms of quantitative analytics and performance. It does not get much better as an integrated health system in the United States of America than Kaiser. And Signify Health, that provides a series of services from technology to human engagement that supports value-based care and payment with health plans and providers across Washington State and in other states as well. So thank you to our sponsors. And to our panelists, I'll introduce them here in just one second. I want to just note for our attendees, however, that in our chat box here on the right-hand side, you can see our sort of place where you can slot in any questions, and questions and comments beget more questions and comments. So as you post those, you'll be able to prioritize them. You'll see a little thumbs up icon where you can tell me which sessions or which questions rather you would most like me to integrate into the conversation, and we'll make sure that we get your voice included as well. So without further ado, I want to introduce our panelists here today. First, we have Representative Milan Tai, who serves in the Washington State House of Representatives. We have Leanne, the CEO of Community Health Plan of Washington, and Dr. Ollie Thomas, the Medical Director for Healthcare Career Pathways at Kaiser Permanente of Washington. Thank you guys for being with us. I appreciate it. Representative, and I'm going to refer to everybody by their first names because we're all friends here. So Milan, tell me first, how was this session? How did you sort of make your way through it, and tell us a little bit about the work that you were engaged in there?
Well, thank you so much for the opportunity to be here with you on a beautiful Pacific Northwest, sunny, warm weather. I was sincerely hope that I can get out of Zoom after sessions, but apparently that's not the case. Oh goodness, the session was absolutely amazing. Just like any sessions, this would be my 3rd sessions in this capacity. And just like any sessions, there's so much to celebrate and there's so many heartbreaks. And as somebody who background in healthcare, I graduated from University of Washington in a School of Pharmacies. Healthcare has been my first love, my passion. We've done quite a bit considering the situation, the pandemic we are in, which is in itself a healthcare crisis. We have put that on the top of our agenda as far as the legislative sessions, and I am pleased for some achievement and yes, heartbreak for others. And I love to engage with the audience a bit more about those and look forward to doing more work for Washingtonian.
Good. Well, thanks for serving in the legislature. We appreciate it. Leanne, how about you? What is commanding your attention these days?
Well, good morning, and I'm also very happy to be here. Thank you. I love to have these conversations. We're very involved in all aspects of advancing health equity. That's really our focus as an organization. We're working in tandem with the community health centers across the state in order to really be more intentional and effective in our health equity efforts. A lot of that means focusing on strategy associated with social determinants of health and recognizing the role that we play in improving people's social determinants, those factors, and also being intentional as an anti-racist organization. We're doing a lot of work in that regard. We're, in very concrete terms, we're looking at opportunities to increase access for individuals and communities around access to care with telehealth as a important tool that emerged from the pandemic. And, we're recognizing the importance of collaboration across the stakeholders and across community-based organizations.
Great stuff. Well, thanks for the work you guys do. I know Community Health Plan is sort of one of the proud kind of children of Washington State healthcare, unique to Washington State in many ways. So, Ali, how about you? Tell us about the work you're doing at Kaiser.
I'm really excited to be here. Thank you, DJ, for this. And what we're doing at Kaiser is actually why I ended up coming here out of residency. I saw that group health at the time was going to be a leader in terms of health equity, and I came and I spent 3 years here before I did my MPH at Harvard doing minority health policy, and came back. I helped Representative Lori Jenkins write the community benefit law. I provided some content expertise, and I kept working. And most recently, for the last couple of years, I have been thinking a whole lot about the workforce, the healthcare workforce, and the lack of diversity in that workforce. During my training, I felt quite useful as a Mandarin speaker. By that time, I had gone to China several times and spent a lot of time in Chinese hospitals. And when I was in my residency in Chicago, I actually I thought, more useful talking to Black patients. I had a patient I remember who had lymph node swelling under his armpits, and we thought he had cancer. He'd had 2 biopsies that were negative, and he thought we were experimenting on him. And I was the only one who could really talk to him about, no, we actually do need to do it a 3rd time, because we really do believe that there is something here. He didn't trust any of the other providers, and this is why we really need to have providers who look like the communities we represent. But in all my travels and in my time as a physician for 20 years, we basically don't believe that this is actually something that applies to our Black, Indigenous, Latinx, and Pacific Islander patients. So what I'm doing is trying to fix that problem, and I'm working with a great group of people, both at KP and in a community capacity. I'm one of several leaders working to create a new nonprofit, which will be called the BIPOC Health Careers Ecosystem. We expect to be fully launched by the end of this year.
Wow, great stuff. Not just as a caregiver, obviously, but in terms of all the other stuff as well. I'm glad to have you here with us. I want to turn to our first slide here, which is a slide that we've contributed. I've contributed, our team here, and for explanation, we have 5 slides here. We're using this sort of platform of a multimedia environment where each of our panelists have each brought a slide. We contribute 1 slide at the beginning and 1 slide at the end, and that way we can take a graphic and illustrative image and try to wrestle the implications of that image to the ground together. This first slide is a little detail around social determinants. It's something that has gotten, I think, embraced by the mainstream of healthcare over the last 10 years or so. And we use the term social determinants regularly and sometimes a little too loosely to mean things that impact our health that are not healthcare service related. We wanted to contribute this slide because it puts some detail into what those social determinants actually are. Sometimes people overlook that a social determinant is, for instance, not just economic opportunity, but the amount of debt that people carry. And you see that in that first silo on the left side. You also, as you sort of go through, you can see things like the quality of playgrounds is a social determinant. Whether kids have a safe place to go that is close to their home, where they can be outside and where parents can let them run free and be kids. So looking across this spectrum, of course, the healthcare system is on the right side, but there's so much great detail. I think the stress in the light blue, stress, the trauma, exposure to violence and trauma, we have historically thought of, and rightfully, I think, thought of exposure to violence and trauma as an acute thing experienced by communities and individuals, but it is also sort of a chronic thing. Certainly the case in instances of race, but also things like a pandemic, where we are all going through a pandemic together, and it will leave some lasting trauma with many of us. So, Leanne, when you think of the granularity, when you think of this slide and the granularity of some of the social determinants, how do you kind of maintain focus as an organization that is committed to being anti-racist, to addressing health disparities, to addressing social determinants, when there are so many places for that effort to go?
Yeah, I that's a great question, because I think it's easy to feel overwhelmed and say this problem is too big for us, and so let's just focus on, medical services. But that would be mistaken, because we can make a difference, we can make an impact, and we have to recognize in what area do we have the assets, the resources, the skill to make a difference, and how do we work with others in the community to tie these things together. So as a health plan, we have access to data, we have analytical capability that can help us focus on where the need is greatest, and then we can also have programs that help refer people to social service agencies and community-based organizations that may provide the direct services. So we may not ourselves as a health plan provide those direct services, but we can have the bigger view of what the services are that are needed and form a lot of those connections. And that's real. That could really make a difference. We have, stories after stories of care coordination, care management, and community support services within the health plan itself that, really make a difference in people's lives. But in addition, in working with the community and working with community health centers, we don't have to do it all ourselves, right? And in fact, that would be a huge mistake to try to do it all ourselves. But by working with others, we can provide information, we could provide support, we could help fill gaps, and together come up with programs and opportunities to address particular areas of need.
I agree with the idea of not being overwhelmed. Particularly, I think we need a lens of anti-racism. I think we can understand these issues only if we understand it through racism. And I think one of the lessons is the leadership of communities of color.
The number one lesson that I've learned over time is humility, and to know what I don't know, and to know what we as an organization don't know, so that we do rely on the voices of people who are most impacted. And that's not easy to do. That we all have a natural sense of we're experts, right? We think we're experts. We've gone to school, we've had experience, we've done experience, particularly in our professional life, but that doesn't make us best qualified to serve people in terms of understanding their needs. And so I think you're right on.
Can you guys hear me now?
We can, and we can see you as well.
Well, I had to jump over to one of our team members' desks, and now I've got his headphones on, and so we're just rolling with it. It's the world of technology. That's how it goes. Anyone else want to make a comment about that first slide and the sort of granularity of the social determinants? All right, good. Well, let's go to this next slide. Representative Tai, go ahead and walk us through your slide here first, if you would.
Yes, absolutely. Thank you. It isn't our power structure something? Even though you wanted to ensure that we are here in the space of sharing and being able to see one another as sort of like individuals who has something to contribute to these conversations, my title continued to be sort of like in that background, right? And so, first of all, thank you. And I too will ask the audience to see me as beyond my title, and to Dr. Thomas, sort of conversations with Leanne earlier, and I did that. I call him Dr. Thomas in Sierra Valley. Is exactly that, the very experience and the capacity for us to jump into the space and be that connector, that navigator, who have a lived experience and cultural understanding of how to assist and ensure the integrity of healthcare, of science being promoted. So on my slides, as I shared earlier during the introductions, one of the pieces of data that we dig into and was shared with us during the pandemic is really those who do not, well, first of all, experiencing the infections of COVID-19, lack of capacity for testing, lack of capacity for being quarantined from the exposure to the public. And then now we're in the space of vaccinations, lack of information. So even if people trust the vaccine, being able to get to them has been difficult. And when we keep digging deeper, we recognize that, which is not new. I mean, this is not new. It's just kind of bring it to another level of light shining onto the populations of immigrants and refugees in our state. So on my slides, the 240,000 undocumented people living in Washington is definitely an estimated numbers. These numbers are not up to date, and again, in healthcare, we are determined to serve each and everyone who cross into that space. Because that's what we took an oath to do, take care of people who needed our service, regardless of immigration status. So this number, I want to reemphasize, is an estimated number. It could be more for multiple reasons, but just with the number presenting in this slides, we can see the impact on the individuals who do not have health coverage, who do not have a clear understanding of how our system is functioning. The disparity is glaring in our eyes. We are attempting to reach out through community health plans, through many of the trusted ambassadors in communities to help us. At the same time, when we look at the state as a system-wide, recognizing multiple barriers that we couldn't lift. And we couldn't lift these barriers, recognizing the disparities and all that, is because of the very racist system we function under. We couldn't change. We attempt to address racism in our state, and racism is across the board, whether we're talking about healthcare or educations, or housings or transportations, right? And all of these sectors come together, giving us the what we've seen as healthcare services and delivery disparity, regardless of the intentions and the attempts to provide these services to everyone who live in our state. So I pause just to see if there's any sort of like reactions and engage further in our topic of conversations.
Ali, what do you make of Milan's comments on her slide?
What I find really concerning is the history of racism within our immigration policies, the history that we've had of basically not seeing people who are undocumented as worthy of care in the United States. I think that gets back to just how we were founded, with really as a society that was founded in white supremacy, and the history of bordering that we created in terms of both how we treated Mexicans after we took over half of Mexico, and Chinese after they came, and then we kicked them out of this area, in riots in the mid 1860s, when we kicked them out of places like Newcastle and then later in Tacoma. And then we just kind of keep doing that. We keep it up by excluding them from, the access to things like health insurance. And so I think what we're really grappling with on almost a psychic level is this issue of considering people to be our people, considering people who are coming from abroad and immigrating to the U.S. The the Latinx population and the Asian immigrants that are coming here as part of our own communities. And when we understand that, then we can really and accept that they are worthy of they are our family or our community. Then I think these issues become easier to deal with.
Yeah, anchoring on our humanity, right? I mean, really being able to see each individual as a human who came into our care. And I mean, for those of us who's committing our life and building our career as healthcare providers, and using our knowledge to serve others, that to us is a very clear things to do. And so I'm hoping to put that sort of concept or philosophy into policies as when we're considering policy impacting millions of people.
Milan, I want to ask this question. We got a lot of good comments here in our chat box. And I note that Senator Karen Kaiser is with us, and she says that she's working with the Department of Health to implement her bill to create health equity zones and would be pleased to work with you. Senate Bill 5052 intends to use the health disparities information to change them. And then Cecile Greenway asks Representative Tai, what is the legislature doing to address the Byzantine systems that make accessing health coverage for immigrant populations so challenging? Any thoughts there?
We failed. And again, because the entire system, the entire backbone of the system is so racist in itself, we couldn't even see beyond it. Right. For me, a lot of it is we continue to look at what we call a fiscal note when a legislation is being introduced, and we make our decisions based on the cost. And so what I really want is to really have conversation around it is about an investment. The questions about healthcare for all, the questions about making sure everybody has healthcare coverage and services when they need them, is who pay for them. The reality is we all pay for them, whether we pay as an investment to ensure that people will get their acute conditions being cared for, better yet, prevent from having these acute conditions, versus in the back end. And so I believe that the system could only start moving and changing its directions when it's actually recognizing its inherent racism, its inherent lack of capacity to see each individual as a human, as somebody deserve the service that we provide. And at the government level, at the state level, at the level of policies, if we don't take in that as a concept, we continue to see the have and the have not. We continue to decide whether a life worth the cost, which life worth the cost that society will invest in and which don't. And because of that, the any legislations or policy that would bring benefits to all failed, because we keep put that in sort of comparison. You worth our investment as society, but you don't.
Great. Boy, I was going to ask a question because that's hard to follow, Leanne. But I'm going to, in terms of keeping us on track for time, I'm going to give you the unenviable position of having your slide get teed up here to follow that conversation, and I think your slide segues nicely. So tell us what you brought to this conversation.
Well, first of all, I really appreciate my co-presenters here. I'm so in agreement, and I think that part of our role in this healthcare community is to advocate for these broader policy issues, because we really need to see change, and advocacy is a big part of it, and that's part of my role as well as the CEO of Community Health Plan of Washington and Community Health Network of Washington, is to advocate for these policy changes and to see that type of important idealistic discussion. It's not just about the nuts and bolts. My slide is about the nuts and bolts of what we can do today as a health plan and as a system to tackle a very specific problem. As we know, COVID has really exposed the disparities among populations in ways that, nobody had fully addressed across the healthcare system, and still, it's just tragic, the extent of these disparities. What we're trying to do is take a focused look at areas that we think we can impact very directly and in the short term, as well as working on longer term issues that are perhaps a bit more intractable, but yet we need to work on those as well. As a short term area, this slide represents work that we are doing as a health plan in conjunction with our community health centers and community-based organizations to improve the vaccination rate for specific populations. So the slide represents data that's available to us right now. It's a snapshot in time of data that shows numbers of populations by racial and ethnic categories. That alone is tough to get because of usually people are not that forthcoming when they are asked what their ethnicity is. It's not always captured. But we do have ways to pull together data from a lot of different sources. We have a platform that we use to pull data from medical records, as well as enrollment records and claims information and pharmacy information and public sources. So we pull all that data together, and that gives us a bit of a window into some of the disparities relating to not only diagnoses, but such issues as vaccine rates. And so in other preventative care, we use this also for preventative care services. And what we've seen here is that in this snapshot, you have to really be looking below the line as well as what the top line shows, because you might see that there's percentages that reflect statewide proportion of folks that are vaccinated. But if you look at the county level, or if you look at a particular community, you'll see different results as well. So it's really important to use data effectively to see the bigger trends, but not to stop there. You have to continue to dig deeper. And then you still have a lot of questions. What does that data mean? So we see that Black and African American populations have the lowest rates for initial vaccination in 20 of 39 counties in Washington. We also see that Latinx populations has lowest rates in 6 of 39 counties, but not in other counties. So you have to go to that next level and understand what are the barriers and how can we impact that in a positive way. And that means talking to the folks that are closest to those populations and understanding to what extent it's an access barrier, what extent is it a trust barrier, what extent is it lack of information, language, and so forth. And then working very directly with those community organizations to impact what's needed to affect the desired goal. So that's what's behind this slide.
A lot there. Sulani Manson has a question that I'll throw to you first, Leanne. It's about social determinants in general, but I think your slide informs your response. She says, not discounting the effect of social determinants on health, but is it realistic to ask a healthcare system to provide medical services efficiently and effectively, and to take the lead in social services and social justice? Is it too much to ask? It seems like your slide here is blending the reality of the social justice piece with healthcare's integration, and it shows up in vaccination data. But how would you respond to Sulani Matson's question?
Well, I really believe that we all have a role to play, right? And it's not that any one part of the society can do it all. Within the healthcare sector, though, there are true barriers to our goals of achieving health for communities and for individuals. And if we ignore those barriers and say, oh, all we can do is, make sure people get access to a physician, we're not going to achieve our goals. So if we know, for example, that trust is a major impediment, then we need to work with people like community health workers and organizations that are trusted partners for those populations in those communities. If we're seeking to achieve goals of health, we have to recognize that preventative care should be a focus, and primary care and behavioral health services, and not wait till people have conditions that lead to hospitalizations. So I think we all have a role to play, and understanding the broader picture and the role that social determinants play in people's health is just critical to achieving our goals, our ultimate goals as a healthcare system.
Yeah, I'd like to just jump in on that question too. I think it's such an important one. That's a common one. Sorry, can you hear me okay? Okay. I'm thinking back to a specific patient I had when I was doing an HIV outpatient rotation at Cook County in Chicago, where his name was Joe. He was just out of his prison, and I was assigned to interview him to learn about all of his history outside of his medical care. So it was an unusual kind of a rotation that I was on. And he told me so much about his life. And as a Black male talking to a Black male, it was so interesting to see the juxtaposition. I ended up becoming friends with him. We stayed in contact until he's passing some years later. And I think about the major problem he had was housing. He could not get a place to live because he had a record. He couldn't stay with his mother, whose home I would visit, because she was in Section 8 and he had a record. So at one point he ended up getting imprisoned again because he couldn't get a job because he had a record. So I think about it as when you're a patient, when you're a provider in the healthcare system taking care of a patient, it is not a far stretch to say whatever this patient needs, I'm going to take care of. I've written letters for patients who had heart attacks and didn't have access to a grocery store, and they were trying to get into a better apartment, and they needed to apply to get into an apartment. I mean, you just do what you have to do. I think basically that we in healthcare have a lot of smart, educated people who can solve problems, and even more than we have smart, educated people, we have money. We have, 18 or 19% of the economy. And I think that this is the time, especially under the new community benefit laws that are going into effect in Washington State, July 1st, 2022. We have the policy window to start doing things a lot differently when it comes to community building activities like social determinants of health.
I will say and make sure that all of my microphones are on. You guys are champs as panelists for powering through while I'm bouncing around doing all this stuff. And to our audience, like Maria, who's telling me we can still hear you. Thank you guys for bearing with us. I appreciate it. Ali, let's transition. Let's use that as a segue to your slide now to talk about the data and the graphics that you've brought. There's a lot going on here. Tell us about it.
Yeah, thank you. So I'll start off by saying that, we have missing people in our healthcare workforce despite a projected shortfall of between roughly 55 to 140,000 physicians in 2033. That's what we're expected to be short. We have systematically underutilized our people. Our most marginalized people are not there. They're not working as psychologists, social workers, researchers, public health providers, advanced nursing practitioners, midwives, dentists, and physicians. And this, what the slides are showing that what the slides show is that we do have diversity. However, the diversity is concentrated on the right side of these graphs in careers that have too little training, too little influence on life and death decisions, and too little power to transform systems. And I think this is by design. I think people need to understand, at least in medicine, that when our healthcare system was, our medical education was set up, the architect, Abraham Flexner, wrote a report in 1910 in which he said the medical care of the Negro race will never be wholly left to Negro physicians. So this exclusion has simply broadened to include other minoritized groups. And I can say as a physician for nearly 20 years that practicing clinicians don't even question the status quo as untenable. So what we have to do is we need to get more underrepresented minoritized groups into healthcare leadership careers. And the way we need to do that, there are a lot of ways. I think everyone has a role. When we talk about, we were just talking about the community benefit obligations that are on hospitals now and the new clarifications to the law. And there are now additional community building activities. So the key to understanding community benefit, I think, is to know that this is a quid pro quo for not paying taxes, that these hospitals owe community shareholders, we can think of our communities as shareholders, a return on their tax-free status. And the IRS has clarified under the ACA, and now the Washington State Legislature has also added that hospitals can do things like help with housing, like I mentioned about this patient Joe, help with food. And what I'm proposing is that they also help with education. Education is underfunded for the students we need to end up in healthcare careers. What would be the problem with paying for scholarships for Black, Brown, Indigenous kids to go to a health professional school? So that's one thing that I think that policymakers and hospitals can do. And then I mentioned earlier that I'm helping to form a nonprofit called the BIPOC Health Careers Ecosystem. And so what that is really weaving together when you see that on the right, weaving together stakeholders from around the state and finding ways for different stakeholders who are serving Black, Brown, Indigenous students from K to college to help one another in serving these students better. We think of it as this. We've all been to potlucks. You do your best to make the best dish you can. You bring it, we're all bringing our collard greens or our sweet potato pie to this potluck. And then we're sitting in front of students and they're all over the place because there's no table in the room and there are no chairs. And so what we're trying to do is to build that convenience space, and building a space for different stakeholders to come together. Investing in that is also a community building activity that can be paid for by hospitals. So we need to do a lot more collaboration. We need to do a lot more investment, and we need everyone to step up.
Yeah, of course, we are big proponents of creating places for people to get together. There are not enough of them, and Facebook does not help us in this sort of age of social media. Let me ask you, Ali, about you mentioned that some physicians don't even see the healthcare system as untenable, which I think there's a lot in that simple statement. Seattle is a community of neighborhoods, and there's a series of different kinds of communities and cultures alive in Seattle. In the white community, sometimes the white community is very colorblind, and I think a lot of folks have been raised to be proud of being colorblind in the white community. they don't understand how that can be an obstacle to their relationships. How do you help bring folks who are colorblind and take pride in it? How do you bring them along in a conversation where they can see the health system for what it is, and where colorblindness does not help them in that regard?
Well, I'll have to challenge the premise slightly in terms of saying that we can't always wait. So one of the premises of my work is that we have to start with the leadership of the people who do understand already. So starting with communities of color is part of my modus operandi in this work. But secondly, I think, Seattle is full of well-meaning but undereducated people, white people, who have still to understand that there is a heritage of white racial justice champions. We don't just have a history of white racists. I think people are afraid to learn history because of that. There's also a history of people like John Brown, who died trying to free Black slaves, or the Grimke sisters, or people who are abolitionists, even though they did have their own challenges in terms of inherent racist beliefs. You have people who you have who was it that Cesar Chavez worked with. I'm looking at the book that was written by his mentor, who was a tall white guy. I'm trying to remember. Sorry, I forgot. But you've always had white racial justice champions, so people need to understand that there have always been white people who study this issue, who understood this. It's never been easy, and you can't sit on your laurels. It's very hard to move from the head to the heart. So we have a lot of people who think they understand it here, but until they feel it here, and until they understand that they still, when they're in their head, are unconsciously have an unconscious superiority, until they get to their heart and get to a space of humility, then they're not yet ready to help us out. And finally, it's not about guilt, it's about responsibility. White supremacy is, as Dr. Eddie Moore says, white supremacy is not hyperbole. It is the fact of how this system was built, and white privilege is the benefit that you get from just living in this system and looking like the people who built the system. But it's not about the guilt. It's about the responsibility you then have to translate your power into policy changes.
So, Leanne, how about you in trying to build an anti-racist organization? How do you bring along well-intentioned, well-meaning folks that just don't have a lived experience of a diverse setting, or they don't have the vocabulary or the skill set to move past colorblindness?
Yeah, I really appreciated what Dr. Thomas said. I think it is about being educated and learning from others and having the humility. And so we, as an organization, are investing in our culture, what we're calling a culture of equity. We started, working in a more classical DEI curriculum, but we're moving away from that to a curriculum that does work with anti-racist and history as part of the curriculum. And we've engaged a consultant. We can't do this ourselves. We've engaged a consultant that's worked with healthcare organizations that will help us on this journey. And it's part of our work. If we don't address our own internal culture and our internal limitations, we can't be successful in our external work. We have to tie it all together. So I really do appreciate Dr. Thomas's points. We try to learn from that.
I think one of the best bits of advice I've ever given, or ever received rather, on this subject is to just shut up and listen. And so I appreciate that you guys are here talking and I can do the listening. Let's move to our last slide here in this conversation. This is one that we contributed in the mix, and this is just the median income and net worth, median net worth and mean net worth of individuals by race in the United States. It shows that there are wide variations in that white families have much higher, multifold levels, higher net worth, and both in terms of median and mean. These don't happen accidentally. I think these happen through structural reasons over time. There are a lot of those. We started our conversation today noting that in the social determinants, at least on the slide that we provided from the Kaiser Family Foundation, the economic health of the community was a social determinant of health. And it's just harder to be healthy when there are structural reasons that make wealth accumulation, intergenerational wealth accumulation, difficult. In other words, if you're poor, and you don't have the same opportunities and you don't have the same education, all the stuff that we've been talking about here today, it just leads to an intergenerational transfer of poor health outcomes. So I'm wondering, Milan, when you've just left a very progressive legislative session, perhaps the most progressive in Washington state. I go back to at least 1987 and maybe even before that, maybe even into the early 1970s. You made a lot of effort to try to address economic challenges in Washington state's economy. How do you keep up hope? It sometimes feels like we're trying to boil the ocean and trying to tackle a huge, huge problem. Sort of bridge for us our conversation we're having, the legislative activity and activism, and then the future. How are you feeling about it all?
Well, thank you for the questions. I love how you frame it in terms of how do we keep up hope. I'm going to start with personally. Personally, I'm a refugee. I came from a hopeless place to a place where I believe we have capacity to build. I have said it in many of the platforms that I have the privilege and opportunity to speak to, is that refugee and immigrants are the strong people, or people who's like perpetually hopeful. We believe that if it doesn't happen in our generations, it will happen in our children's generations. And so that, to start out with, as my personal journey, as how I bring myself in this place and in this work. And secondly, being a healthcare provider myself, we believe in progress. We believe in, if we intentionally identified a problem and working to solve the problem. And what Ali shared earlier, when we are capable of connecting our brain, our intellectual, with our heart, our compassion, when those two combine together, we couldn't help but being hopeful, because the future is possible when we see the future. And when you work with leaders who has visions, our aims, our goals, our end games might be different, but the visions that we're working toward really align with one another. And then the other piece that I would add to how this legislation has been so progressive, number one, the people who are being elected to serve in these positions are those who came from communities that has been marginalized, that their voice has not been heard. And somehow, because of our skin color, we was deemed not capable. And now these individuals get to have an opportunity to be in a space where decisions can be made and policies can be debated, and contribute their talents and their effort, their knowledge, and their hearts. It's deemed to be progressive. And another piece is that, at least I can speak for the House Democratic Caucus, we were aware of the inherent racist system we were functioning in, and being at the level of the power structure, right? At the state, as a legislature, we asked ourselves, how do we change that structure? How do we educate ourselves? And we have intentionally put funding and time to educate legislators. about what systematic races look like. What does a racist look like? When we speak of color blindness, how is that an inherent racist as a comment? Right, it's like the willingness to put a blindfold in our peripheral, the willingness not to see another individuals as their full being versus stop at the color of their skin. So those really contribute to so much hope, so much capacity, and the engagement. I mean, because of the Zoom world or the Teams world or multiple different platform, the legislature this last sessions has been able to reach out and engage people who lack of transportations, who lack of time, right? Those who has historically been able to engage in this democratic process that we are pushing forward and we're trying to protect has not been part of the conversations. And because of this, they has been part of the conversations. They've been able to share their stories, their personal stories that change the heart and eventually change the mind, would lead to so much amazing outcome of the sessions. You can see how I'm pretty happy about what we just did, and really look forward to 2022.
Yeah, great. Leanne, how about you? What gives you hope as you look forward to the rest of 2021 and beyond?
Well, it does feel like we're in a movement, that we've recognized that we need to progress. And we haven't quite figured out, how we do that all together. And there's such continued divisiveness in this country. There's no question about that. But I feel that there is a force that's moving forward, and that we don't have a choice but to move forward, right? I mean, going backwards is just not, ultimately it's not possible. So we've had our bumps and we're going to, struggle. This is not going to be easy, but we have no choice but to move forward. And I really appreciated hearing Milan words of hope and her passion, because that's what we need. And there's so many people that are joining together with that as our goal, to make progress, to do better. So I'm very optimistic as well, despite the pain and struggle that we're all having to go through.
Ali, how about you? I'll give you the last word. What are you hopeful for when it comes to 2020 on and beyond?
A lot. I mean, above everything, I think, just the power of collaboration. I'm just, listening to Leland, Representative Tai, and I'm thinking how, and you in terms of this forum, and thinking about how in my faith belief, the Baha'i faith, there's a quote that the power so powerful is the light of unity that it can illumine the whole earth. We really can accomplish amazing things through unity. And so having people of goodwill working together, I think that's what gives me hope, in general. And then specifically, I would say that community benefit bill that I referenced earlier, and I got the reference, is 70.41.470, Section 5, where we can really begin addressing the wealth accumulation issue, which I need to point out amidst my Native American students and my Pacific Islander students' families, but that really can look at underdevelopment. In the educational system, we have a problem with underdevelopment of all of these students, minoritized students, and over discipline. But if we could have more support for educators, from community benefit programs, there's so much need for investment from hospitals. That gives me hope too.
Great stuff. I appreciate you all being here with us. Dr. Ali Thomas at Kaiser Permanente of Washington. We have Representative Milan Tai, of course, of the House of Representatives, and Leanne Burge, the CEO of Community Health Plan of Washington. Thank you to our sponsors, Signify Health, Kaiser Permanente of Washington, and CHPW. And I would just say, thank you guys for being a part of this, both our panelists and our attendees. whatever the solutions are on the horizon, they will require more conversation and not less. So go find some uncomfortable conversations and lean into them. That's how we will grow as individuals and as a community. We'll do this again soon. Thanks for supporting our work at State of Reform, and we'll be in touch soon. Thanks, everyone.